Hello, my name is Professor Raj Persad. I practice in Bristol and in London, and I have a strong interest in prostate diagnostics. We all know how common prostate cancer is, but are we aware of some significant recent changes that affect men being investigated for the possibility of prostate cancer, and the improvements in the diagnostic tools we now have available? Of course, diagnostic tools are important, and it's great to have the best ones possible, but these tools also have to be used beneficially in the hands of those who are experienced. So just to recap historically, the majority of early prostate cancer patients are diagnosed by referral from their GP to a urological specialist with an interest in prostate cancer with an elevated PSA. There are a few extra markers of suspicion, which I'll mention now. So if there's a positive family history for prostate cancer, i.e. any of your brothers or father with prostate cancer, that heightens your risk. Ethnicity is important. Black patients have something like 3 times the incidence of prostate cancer. And also patients in whose family there runs a history of breast cancer with the presence of the BRCA2 gene. Now, if one is diagnosed with an elevated PSA, one will go to specialists with an interest. Now, in previous days, based on an elevation of the PSA, one would be sent forward for a biopsy. This is an invasive procedure, and it used to be, from what I'm about to say, even more invasive and more, how shall I put it, less accurate than what we have available now. Based on an elevated PSA, you might be referred for a biopsy straight away, and you would have a probe inserted in the back passage and biopsies directed through the lining of the rectum into the prostate, the so-called transrectal ultrasound directed biopsy. The way things have changed now, because there was a high incidence of known inaccuracy and a relatively high incidence of sepsis, i.e. infection biopsying through the rectal lining, things have changed. We thought, is there a more accurate way of targeting suspicious areas in the prostate to make our biopsies more reflective of the disease we're trying to diagnose? We know the accuracy of transrectal ultrasound was poor, but by doing an MRI first, we are now able to A, diagnose areas that need biopsying, which we didn't know before, and B, in some cases, in a large percentage of cases, up to 40% in some series, we are able to avoid a biopsy at all, because the MRI, used properly and interpreted correctly by an expert in the field, can actually give you a result in terms of telling you how low your risk is of actually having prostate cancer, and therefore give you the option to avoid biopsy. So you'll have gleaned from what I've said is that MRI scanning, so-called multi-parametric MRI scanning, prior to a biopsy is the new pathway gold standard, if you like. You should not go forward for a biopsy without having an MRI scan first, where possible. There are, of course, rare cases where you can't do an MRI scan for medical reasons. Having now introduced MRI scan before biopsy, we have also, amongst the specialists, developed a much more sophisticated and a far safer and more accurate way of biopsying the prostate. This is the so-called Trans-Perineal biopsy of the prostate. So, with the scanning probe still in the rectum, because that is the appropriate place to scan the prostate from, one targets the areas in the prostate for biopsy with a needle that is fired through the perineal skin. In other words, the skin anterior to the rectal axis and posterior to the scrotum, the perineal area. We have found that this can be done under local anesthetic with vastly reduced infection rates and far greater accuracy. So just to recap, I've said MRI scanning, a good quality MRI scan in a center of excellence reported by an expert, can A, avoid you having an unnecessary biopsy, and B, lead to a greater accuracy of diagnosis in patients who do have the disease. Remember, with the transrectal biopsy, it was very much a hit and miss affair. Now with the sophisticated MRI, we can target areas that look abnormal on the MRI. There are some important implications of a good quality MRI for further treatment. I'll start with focal therapy. There are cases of prostate cancer where accurate MRI and biopsy has shown the disease to be predominantly in one lobe of the prostate. We can target this area and not treat the area that is not involved with prostate cancer. And this, the merits of this is that you get far less in terms of side effects. Focal therapy has been shown in trials to be very satisfactory in controlling the disease and in reducing horrible side effects relating to bladder function, erectile dysfunction, and continence. For you to be able to put forward a proposal of focal therapy as a treatment choice, you have to have confidence in your MRI and your transperineal biopsies. Secondly, if you are the sort of patient who has been advised to have radical surgery, in other words, nowadays, this is usually robotic assisted laparoscopic prostatectomy. This is the keyhole procedure with minimal trauma and better functional results. But if you are doing this procedure, you want to be sure that you know where the disease is in relation to your surgical cut. You do not want to be shaving your surgical margin close to bulky disease or where there is high-grade disease. The MRI, and there are ongoing trials in this area using something called the neurosafe procedure. But basically, the MRI will guide you as to how wide a margin to take or how wide a berth around the cancer you need to take to be safe. It can also tell you how close you can go in certain areas where you would like to preserve the nerves to erection, to preserve better function, particularly where the MRI has shown there is not any bulky disease towards the edge of the prostate on that side. So in summary then, not only is a good MRI able to characterize the prostate and give you a very accurate diagnosis and guide your biopsies for later treatment, because of course, if you don't have an appropriately characterized prostate, i.e. properly biopsied with accuracy, you can't actually tailor treatment as well as you should do. So MRI and a good biopsy will help advise on what treatment downstream is necessary. if you are found to have prostate cancer. It can also obviate the need for prostate cancer with a great degree of confidence in up to about 40% of patients. And finally, biopsy and MRI will advise the surgeon, if he's undertaking removal of the prostate, as to how close to make his surgical cuts with the robot. And it can advise the more conservative treatment of focal therapy as to where the treatment should be targeted to minimize functional side effects post-treatment. If you have had an MRI scan and you have any concerns, or your clinician has any concerns, you are perfectly well entitled to ask for a second opinion. Now, this happens almost routinely in the NHS, where we have centres performing diagnostic procedures, MRI and biopsies, and they refer patients to the tertiary centre or the cancer centre, where all results are reviewed and re-examined by experts in this field. If you are being operated on or treated privately, it might be more difficult to get the second review, but your private insurance company should support you in getting a review of your MRI, as it is good practice, as well as review of your biopsies. So that's about it in terms of MRI and biopsy in the diagnostic pathway of prostate cancer. Thank you very much.